My name is Professor Nicholas Harvey and I work at the MRC Life Course Epidemiology Unit at the University of Southampton. And I'm here at this 2017 Ortomed conference to speak about calcium vitamin D. And I focused principally on the efficacy of calcium vitamin D supplementation, and that across a range of meta-analyses there's evidence that such interventions give a modest benefit for reduction of fractures. However, one of the key issues in supplementation with calcium vitamin D is that of cardiovascular safety. And so in my lecture here I've just summarised the range of studies and meta-analyses in this area. And I think it is apparent that the evidence is complex and needs to be approached in a very detailed, nuanced way. So across the various meta-analyses, there is a mix of associations between either calcium alone or calcium combined with vitamin D, and a range of cardiovascular outcomes, but inconsistent across those outcomes. Other meta-analyses show no association. I think overall it's apparent that because there is a range of outcomes defined in different ways, the study designs of the original trials are very heterogeneous, the people included are quite mixed, and particularly there's a dearth of men. It's very difficult to be sure of any relationship between calcium vitamin D supplementation and cardiovascular adverse events. To answer this question properly, we would need a suitably powered randomised controlled trial with suitably validated outcomes. The problem is that this trial will in reality never happen, and so we have to make the best of the data that we have. So the conclusions, as far as I understand the data, are that yes, for calcium vitamin D, but rather less so for calcium alone, there's evidence of a modest benefit for fracture reduction, most in institutionalized individuals rather than community dwelling individuals, that there is an increased risk of GI and renal side effects, so renal stones, with calcium supplementation, but that the evidence linking calcium or calcium vitamin D with cardiovascular side effects is not convincing. There's perhaps a residual concern or signal that comes from a number of studies for calcium alone and myocardial infarction, but this is based on only around 6,000 patients compared with, say, 60,000 for calcium and vitamin D. So I think the message for clinical practice is that we should target these supplements to where they're most needed, and that is people who are likely to be deficient in these nutrients, for example the institutionalized elderly, and for people who are on anti-osteoporosis medications or have other metabolic bone diseases needing supplementation. There's not really any justification based on the evidence for community supplementation approach, but so these interventions should be targeted where they're needed most.